Good morning and welcome back to another edition of the Lynn Lowdown. I'm Danny Vittori, and today we have on the CEO of Lynn Community Health Center, Dr. Kiame Mahaniah. So thanks for coming on the show.
Honored to be here and glad to be here.
Great. So one of the things you came on to talk about was the new pharmacy that you're developing within the health center itself. So would you want to maybe talk about that a little bit?
Yes, so in either the second week of January, we'll have our soft opening with the official opening in the third week. We'll be opening Lynn Community Health Center's own pharmacy. It'll be in our main building, available to anybody in Lynn, but really focused on our patients. So we're pretty excited. We've never had our own pharmacy, so this is a brand new venture for us, and we're very excited.
Because I don't know if I'd heard of it either before, a health center actually having their own connected pharmacy. And you were talking a little bit about a lot of the benefits that can come from having that connection. Did you want to?
Yeah, so it's not unusual for a health center to have a pharmacy. So for instance, if you went to East Boston, they have their own pharmacy in-house. If you went to Holyoke, they have their own pharmacy, or Lawrence. But yes, it has not been something we've done. It's not something really in the area that you would see. But I mean, obviously the great benefits are really that you tie what's happening for and with the patients in the health center more closely to the pharmacy. So as many of your audience may know, the pharmacy, the health center really specializes in providing care and services to people who have difficulty accessing the mainstream system or who can't access the mainstream system. So we have a lot of people who prefer to be served in language other than English. The vast majority of our patients are below the poverty line. And also we have a lot of people who have literacy issues. And obviously we have a lot of seriously ill patients, and they can have a really difficult time accessing care. So the idea is really that to connect the clinical pharmacy services really intimately with the team, so that for the patient, it won't look any different whether they're talking to the nurse, the medical assistant, the nurse practitioner, the pharmacist. They would all feel like it's part of one team, so that we can really tie, call it closing the loop. But we really if I just give you a medication, there's no real guarantee that you understand what it's for, that you're going to go get it, that someone's going to explain to you how to take it. So this is really guaranteeing that, particularly for our patients who would have a difficult time in a mainstream pharmacy, if you don't have a phone, if you don't have internet, if you don't speak English, if you don't read. So those are really the target population for us.
Yeah, that makes sense. I mean, even the last time I got any kind of a prescription there's just pages and pages of directions and warnings and things that I'm like, I don't understand this. So I have obviously I know it's safe, but it can get so complicated.
Not only that, but you get this medication, you're excited about it, and then you read, you could die, you could lose a finger, you could have a stroke, and you're like, I'm not taking this, right? And so the idea is to be able to address those questions, those concerns right away. And then there's a person you can call and say, I started this medication 3 days ago, I'm feeling this, is it related? So we're really hoping that we can bridge that part. So because I forget what the numbers are, but a sizable percentage of prescriptions that are written for in the US are never filled.
Really?
Yes. I can't remember the numbers exactly, but something like only 3/4 of medications that are prescriptions that are actually written, the patient actually fills them and goes to get them at the pharmacy. And obviously, if you have a seizure disorder or you have depression or you have diabetes, like that's a big deal if you're not taking your medication the way you're supposed to.
Definitely. And you were mentioning too, one of the other reasons you were able to do this is you're transitioning, or will be in April, I think you said, to a different kind of payment. Instead of the fee-for-service, it's value-based payment. So.
Yes, so that can get complicated, but essentially the easy way to think of it is that until now, for the last, I'd say, 70 years, since World War II, essentially we've been paid fee-for-service. Means if you come for one visit, we get a certain amount of money. If you come for 2 visits, we get double. If you come for 3 visits, we get triple. And that's just the way we got paid. And obviously, there's lots of things that we do that help patients but that you can't bill for. So we help people sign up for insurance. We hook people up with the food bank. We help people with their housing. We help with transportation. And all those things actually, there's no system to be reimbursed for it. So most places don't offer those services. But now in a value-based payment, what will happen is Medicaid or Mass Health will give us a certain amount of money every month dependent on the number of patients that we have. And to a large degree, we do what we think is right for the patient. So it doesn't matter to us if you come 10 times or 1 time, like it will be, right? And so that kind of change makes us think, oh, so now we can invest in something like a pharmacy and having pharmacists, because we really know how important the therapy is to patients. But yes, without fee-for-service, it's a little bit more difficult to imagine doing something like that. And we're very excited because, like I mentioned before, when you deal with patients who have all kinds of quote-unquote non-medical needs, the fee-for-service system is difficult to navigate. And my big hope, my big desire, ever since I went to medical school, was really to work in a system where we have this value-based payment, where we get money essentially paid up front, and then we have some amount of independence to do what's right for patients.
Definitely. And that, you said, helps the patients too, because they can get whatever individual help they need without having to worry as much about, like, oh, what is this going to cost? How do I access this? It really helps them as well.
Yes, and so one of the nice things is also that really at the base of it, what value-based payment allows you to do is that if a person needs more support and more help, you can actually do it. Like right now, as you know, when you go see your clinician, whether you have a hangnail or you have a really serious medical problem, you get the same 12 minutes or whatever it is, right? And under a value-based payment, what you can do is be like, oh, Danny, she has an easy problem. We'll give her 5 minutes. But, oh, this person, well, it looks like they have a really complicated thing. Let's give them half an hour or 40 minutes. Or, oh, they don't need just the doctor. They need the doctor and the social worker and the case coordinator, and right, so you can really, and so that allows you to be much more patient sensitive, and so it'll take time. It won't happen like magic on April 1st, but nevertheless, you're quite correct that patients will really feel the difference in terms of having all their needs met, and there's no longer this need to come for a visit, right? Like you don't have to feel guilty that somehow your doctor is doing all this work or your nurse practitioner is doing all this work and they're not getting paid. Now, it doesn't matter whether you come, whether it's on the phone, whether it's online, we'll be able to provide all those services. And because of the way we're paid, it works out.
Yeah, which said it does. It sounds like a fantastic system, something to transition into that you're clearly very knowledgeable about. And I guess one other quick thing that I'll go back to is you were talking about the 340B drug pricing program, which again is another place you said where it can sometimes help you with cost, also with patient care. Would you be able to do a quick summary of that?
So I'll try to make it so it's interesting for your audience. So essentially, the 340B program is specifically made for institutions that serve people who are poor. So it's specifically made for institutions like community health centers. And what it allows us to do is that it allows us to buy medications in bulk at the lowest price that's possible in the U.S., to sell it to insurance companies when they're paying for patients, and to use the difference and to keep essentially the profit of that, the difference between what we pay and what we sell it for. And the reason that's so important is that most of the services that we provide at health centers in general, are money losers, right? Like we have, like I mentioned before, we do a ton of work in all kinds of different areas. And most of the work that we do is not reimbursed and would be losing money if not for the 340B program. And one of the other things that's been changing is that the federal government has been moving us towards the idea that, well, if you really want to keep that 340B program, you have to have your own pharmacy. They're making it less and less appealing. So we still have a deal with CVS and Walgreens to run our 340B program. But the federal government is making it less and less attractive that way. And they really want you essentially to have your own pharmacy that you are running, partially so that they can be sure that the 340B program is going towards the people and institutions that it was intended to. So yeah, that's another reason why we're also opening our own pharmacy, is to increase the chances that we'll still be able to get that money, which allows us to fund things like the mobile food bank that we do, or the way we help enroll patients with insurance. That, so you don't have to be a patient of the health center to get our help to enroll. So yeah, so the 340B program is really a lifesaver for us as an institution, and the pharmacy, in addition to being something that's going to be wonderful for patients, also allows us to better survive financially.
So it's all interconnected, patient care, the way that it all works.
Yes, it's all interconnected. Yeah, in general in the world, we like to think of things as completely separate. But yeah, everything is interconnected. And, like one of my big things is people often ask me, what do your patients truly need? And my answer is, wow, they really need good jobs. They need great transportation. They need great community. That's what health is also, that, right? Health is also having good sidewalks and great parks and supermarkets you can buy fresh food at, right? It's not all just the quality of the medical care you get in an office. So the pharmacy really does fit within that overall picture.
I think it definitely does. And I want to thank you again for coming on to talk about it, to tell people about it, and really help explain it.
Thanks for inviting me. I know that sometimes these specialized topics can get pretty dry, but I do think it will be a game changer for the 43,000 patients in Lynn that we serve.
Definitely. And you make it very interesting and easy to understand, which I think is very helpful.
Good. But thanks again for inviting me. It was great being here.
Of course. Thank you so much again. And once again, I'm Danny Vittori. This has been the Lynn Lowdown, and we will see you next week with more guests.